Yeah.
Is there a threshold for the amount of viral load that you need to?
It's a really great question. We don't know. All we know is it's worse in people who have detectable HIV viral loads. It's not as bad in people who have no viral load, but it's not zero.
Is there any danger in vaccinating people that are HIV positive with the HPV virus?
It's a great question. So that is a logical thing to look at, which we have done. And you might worry, for instance, if you vaccinate an HIV positive person, their T cells might go down, and the viral load might go up. The answer is no. It appears to be just as safe as in HIV negative people.
So then in theory, as a matter of policy, they were able to change the policies related to when you get someone with an HIV diagnosis that you, or even if we're just vaccinating younger men with HPV, that sort of
We're going to
takes
come
care
back
of
to that
problem.
because that's something that's very interesting. So, remember I showed you how that tear is important in getting HPV down there? We think now that it's not just a mechanical tear, but also a biochemical breach, where that biochemical breach is induced by HIV proteins that are disrupting the tight junctions. And instead of a mechanical tear, it's all these zippers up here that are allowing the virus down there. One of the other very interesting things that Peter and I have actually worked on is the inverse. So I've shown you now how HIV can increase the risk of HPV, but is the opposite possible? This is actually work that we're hoping to do with Mike. And basically, you may know that every other STI has been shown to increase the risk of HIV infection. Gonorrhea increases it, chlamydia increases it, herpes, syphilis. So I said, why not HPV? And there are a bunch of reasons why you might think that. One is that when you have a big wart sitting in the anus, it bleeds quite easily, and it also induces an immune response. So you might have tissues that have more HIV susceptible cells near the surface. In one of the other studies that Peter did, we looked at whether HPV infection increases the risk of HIV acquisition in sexually active men who have sex with men, and the answer was it does, at least statistically. Found that 2 or more HPV types in the anus were independently associated with HIV acquisition in a study in 4 different cities around the U.S. That was the first evidence, not conclusive, but very suggestive that HPV might be playing a role. And since then, a bunch of other studies have been done in the penis and a few in the cervix, 2 in Zimbabwe, showing actually that HPV also is associated with HIV acquisition in those settings. And in fact, in one of those studies, it was a clearance of HPV, not HPV per se, again, probably because of the influx of the immune cells that are responsible for clearing the virus. So this gets back to the issue of vaccination, because we primarily think of vaccination to prevent HPV-related cancers, but it may be that there's another benefit which we weren't anticipating, which is that perhaps by removing some of the HPV risk from people, we're also reducing some attributable fraction of HIV risk as well. So time will tell. So that segues to vaccination. And as you know, Gardasil and Cervarix have been very, very effective in clinical trials and subsequent to adoption clinical practice. I've shown you how the proteins auto-assemble into these virus-like particles. They don't contain any viral DNA, so they're not infectious. But they get injected 3 times, 0 months, 1 or 2 months, and then 6 months, you need 3. And then the hope is that those antibodies are going to get down there where you most want them, right, which is in the anogenital tract. Well, I'm not going to go into all the information about the women, but suffice it to say that it's probably the best vaccine ever introduced. Truly. It is nearly 100% effective, and to this day, we still have not seen a breakthrough. We've not seen loss of protection. So it is damn good. But we were also interested in seeing whether boys should be vaccinated. So this was a study that we did in 2 populations. One was healthy young heterosexual men and a subpopulation of healthy young MSM. They had to be no older than 26, no younger than 18. The bottom line, so to speak, is that for the combined population looking at external genital infection, we saw 90% efficacy to reduce the risk of genital warts on the penis, scrotum, perianal area. So that's great. Doesn't speak to the cancer risk, right? So that's where the MSM come in. And so we looked at prevention of anal HPV infection and high-grade disease in the anus of the MSM subpopulation to see whether we could predict that we would prevent anal cancer. And the great news was that overall we saw about a 77% reduction in AIN and about a 75% reduction specifically in high-grade disease. So it very much suggests that although the vaccine doesn't work quite as well to prevent anal HPV infection, that it works well enough. So, that's me there. We went to the FDA and we presented those data, and they said, okay, you're already approved to prevent genital warts. Now, it seems to be okay to prevent AIN and anal cancer, but that's not the final step, because the recommendations for who gets vaccinated and who gets paid for are made by the Advisory Committee on Immunization Practices of the CDC. So that's me again, getting my frequent flyer miles by now. And in October of 2011, the ACIP approved routine male vaccination. So that means it's on the vaccine schedule, just as it is for girls. Boys should be getting vaccinated. The target age is 11 to 12, but it's okay up to age 22 for most guys. If you're HIV positive or an MSM, it's okay up to age 26. And if you're neither of those, it's still okay to get it, but you may not have it covered by your insurance company. So we do need to vaccinate HIV positive people, ideally while they're still young and not infected, because it's a preventive vaccine. It only works to prevent infection. And if you're going to vaccinate older people, there's a good chance they've already been exposed to those HPV types of the vaccine. Might be safe, but it won't work much either. Yeah.
Well, it's kind of a win-win too, because if you're vaccinating the males, you're also going to be decreasing the spread.
Absolutely. So there's lots of benefits of that.
Or any other parts.
It's called herd immunity.
Yeah.
So you might be protecting women who've not been vaccinated directly. So I'm hoping that the guys here who are under 26 or under 22 get their vaccine. So one of the areas that we're moving towards actually is for women, implementing the vaccine where it's actually needed the most, which is in developing countries. It's expensive. For each injection, it's $130. You can imagine that's not affordable for Zimbabwe and Zambia and all those countries. So recently, the Gates Foundation and others worked together. They brought the cost of the vaccine down. It's now $5 per injection for those countries, and that sounds a lot better. Even that's actually challenging. Still, in most of those countries, the vaccine is the only hope for cervical cancer prevention because they don't do screening. And still, it's not yet implemented widely. It's baby steps are being taken. Last month, I was in Mozambique for a meeting of the First Ladies of Africa. There were 17 First Ladies there to talk about how they can convince their husbands to implement cervical cancer vaccination programs in their countries. So,
I wanted to ask how they went about getting these lower costs. Who was negotiating that and with whom did they
right, so
negotiate?
it's a partnership between the manufacturer of the vaccines and the companies that are subsidizing, because even $5 is below the cost of it's the quadrivalent vaccine is made by Merck. So it costs them more than $5. So it's made possible by big donations from the Gates Foundation, Clinton Foundation, World Health Organization, all that stuff.
Can kids younger than 11 or 12 get the vaccine?
As early as 9. Okay. You don't want to give it to babies. I mean, you would like to give it to babies because it's an easy time to vaccinate, but you don't know. We don't know if the protection will be long enough, right? Because this has got to last them for decades. Right? Yeah.
I've read that there are different genotypes around the world. What do you think about the quadrivalent? Is that going to give enough coverage for these areas that have different genotypes?
And that's number 2.
Oh, okay.
So HPV 16 and 18 alone account for 70% of cervical cancer, and that's great. Those are the types in the currently available vaccine. But 30% still have not been covered, and that's what this is for, the 9-valent vaccine. That's not a misspelling, by the way. Nana is Latin. So the next generation of vaccines, which is still under clinical testing, has got 5 additional HPV types that cover the next most common 5 types of cervical cancer. So the results of that study are actually going to be available very soon. And if it works, then it'll go through that same FDA ACIP approval process. And if it's all approved, then it will replace probably the quadrivalent vaccine. It's a problem though because it's expensive. And for the $5, the quadrivalent vaccine is going to be even harder for the non-valent. They're almost certainly going to pull the quadrivalent off the market, and so then they have a quandary.
What's the cost for these vaccines in countries where they have a single payer system and negotiate their costs for vaccines?
It's confidential.
You know how that- oh, okay. I was
mean,
just curious.
it's a good question. I mean, I'm sure they work out a good deal, but
Yeah.
they don't
I'm just
disclose
curious how
that.
dramatic.
And then the other thing that you may have heard about is that maybe we can get away with 2 doses instead of 3, because it's hard to get people 3 doses. In this country, about half of girls who should be vaccinated get their first dose, and only a third get all 3 doses. And if you can do it with 2, that would also save money. So actually, we're about to start a study in Bangkok where we're doing 2 things. One is we're using a needle-free injector, because one of the reasons girls don't come back and boys is that it hurts. So if any of you have ever had a needle-free injector, it really is painless. And then the other great thing is we're going to try intradermal injection instead of IM, intramuscular, and that allows us to do it with 20% of the vaccine volume. So if that works, then we'll be able to save 80% of the cost for the vaccine. So maybe by the end of this fellowship, I'll have some information for you. And then I just want to finish off by talking about the prevention efforts for people who are already too old for vaccination. That's most people, right? So there's a lot of people walking around with high-grade AIN. And what are we going to do about it? So this is an algorithm that's very similar to the algorithm that's used for women to prevent cervical disease. Our problem is that we don't really have good treatment because there's no virus-specific therapy. All we can really do is whack out the areas in question. You can actually do that with fairly large pieces of the cervix without causing too many problems, but you can't do that in the anus. It's painful. This is actually one of the techniques that we use. It's called infrared coagulation, where we numb somebody up, put a scope in, and then touch this to the lesion, and it delivers heat energy. It's actually not that bad. People actually get up and go to work after the procedure. But so I'd like to do better, and this is one of the other areas where we're trying to do better, to develop gene therapy. And what's happened here is this is one of the HPV proteins, E2, and its normal function is to bind to areas on the area of the genome that controls one of the other sets of proteins, E6 and E7. So it is called a transactivated protein. And anything downstream of this LCR will be activated when E2 is present. So we're using what's called suicidal gene therapy to try and make an HPV specific approach, where the idea is that you make a plasmid and you put the herpes simplex virus binding kinase gene downstream of E2 binding sites. And if that plasmid goes in and there's E2 present, because the cells are infected with HPV, then the thymidine kinase protein gets expressed. Okay? So you only get expression of thymidine kinase in HPV positive cells. And this is like having a natural herpes infection in a way. So that if you give the patient acyclovir or ganciclovir, then that thiamine kinase protein gets extra phosphates added, which makes them toxic. And so in theory, if you have a cell that's infected with HPV and expressing E2, you'll get thiamine kinase protein expressed with that plasmid there, and then you give the patient a pill, acyclovir, and it should kill those HPV infected cells. Great in tissue culture, that's as far as we've gotten so far, and we're going to go into animal models and see if it works there. So the last thing I just want to mention is, what about anal cytology screening and treatment? Our problem is that nobody's been recommended, since we're in the era of evidence-based medicine, since although we know we can get rid of some high-grade lesions, there's one key piece of information we've not gotten yet, and that is that nobody's proven that the removal of the anal high-grade lesions actually reduces the risk of anal cancer. We never actually did that study in the cervix, by the way. We only know from years and decades of following women that the rates of cervical cancer have come down where we treated cervical lesions, but nobody's willing to accept that in the anus. So we're going to have to do a study if we want to see this adopted as standard of care. So this is the big question. And next week, I'm going to hear from the NIH as to whether this study is funded. It's called the HSIL Outcome Study, and it is going to be the biggest study ever. About 5,000 people recruited nationwide with high-grade disease. And we're going to do a randomized controlled trial where we're going to randomize people with high-grade disease, 50-50, treatment versus observation. Yep.
It's current standard of care observation.
Yes. So that's a key question because people say, I'm sure you've said, this guy is the next Tuskegee. Okay. And do you know what Tuskegee is? Did you learn about that yet? Okay. Is this unethical?
They know
Just-
they have high grade.
They know they have high grade. All right. We are going to follow people to cancer. If some people, like in the control group, don't develop cancer, then the study will be a failure, right? Because we want to see if we can lower that risk in the treatment group. So why is this not grossly unethical? Yep.
I just wanted to ask what your stopping rules were for your data safety ones.
Yeah, so the data safety monitoring board will be meeting very frequently and stopping the study as soon as we see a divergence. But we're going to follow for 5 years otherwise. And the reason why I think it's ethical is A, because the current standard of care is nothing. And most of those people are getting nothing right now. So if they're being followed on a regular basis, then they're actually getting more than the standard of care. And then the other reason is because we think that if we catch a cancer really early, we can probably just remove it locally like you would a wart. You can spare somebody chemotherapy, radiation therapy. And then the third thing is we don't know the treatments work. So I might be putting that horrible probe up somebody's butt and making them, getting zapped, and I don't know if it's doing them any good. So for the people in the treatment arm, we don't really know that we're helping them. We won't know that until we do the study. So ask me next week if I'm walking around with a big smile on my face. If I'm looking grumpy, go away. So I'm going to stop there, and does anybody have any questions? Okay, I hope I gave you a sense. Sorry.
Oh, sorry. Do you have a sense of does anal cancer have the same mortality risk as cervical cancer?
Yeah, so the question is anal cancer, we think that if anybody who's untreated will die eventually. If you're caught early, the mortality is much lower. If you're caught in the earliest stages, it's about 70% in 5 years survival. And if it's later, then it just goes down and down. But more importantly, even if it's caught at the earliest stages, the treatment is nasty. Chemo and radiation therapy are horrible.
How do they determine the cutoff age for the vaccination? And why wouldn't it work on older?
So the question is, how do we determine the cutoff age for vaccination? It's really statistics more than anything. It's basically looking at the prevalence of HPV by age and doing cost-benefit analyses where the older the person, the more likely it is they were to have prior exposure, and then the cost-benefit goes down. So the sweet spot, because of American sexual behaviors, cultural practices, is it doesn't make much sense above the age of 26, which doesn't mean that you can't individualize that decision. There are some people who it's really too late for by the time they're 14, and there are others for whom it might be a great idea to vaccinate at age 27. But and we do that. It's just that we tell that person the vaccine is safe. It may or may not help you, and it's probably going to cost you something because you're not going to get paid for by insurance. Yeah.
How long has HPV been around?
How long have humans been around? Every mammal has a papillomavirus. If you go to HPV meetings, there's always an announcement of new ones. Raccoon papillomavirus, elephant papillomavirus. It's part of our ecology.